Good afternoon. We will continue with Professor Amos Korczyn with the lecture, Is Mild Cognitive Impairment a Useful Concept? Professor?
Thank you very much. It's a pleasure to see that some of you don't go out to see the nice weather outside, to enjoy the weather. It's okay.
Oh, it's okay.
So I'm going to talk to you about mild cognitive impairment and discuss this topic, which is widely used, but I think, like everything, we have to sometimes think afresh of what do we mean by it. So we all know that we are not born all the same. So some of us are born with a higher capacity, but then once we get old, so we shift to the left with our cognitive impairment. And we define mild cognitive impairment as being perhaps 1 or 1.5 or 2% below the average, but the average of young people and the average of older people are not the same. We also know that Alzheimer's disease does not start overnight. There is a pre-symptomatic phase which is quite long, 5 years, 10 years, 15 years, maybe even longer. We don't know what is the definition of the starting point, but we know that biological changes occur before there are symptoms. And it's important to know who is at risk to develop dementia, and only then can we perhaps do something about it. Now, mild cognitive impairment is a new term, maybe 20 years old, but it was preceded by many other terms. And each one is a little bit different, but a lot of commonality between them. The idea is that people with dementia usually do not develop the cognitive impairment overnight. It takes some time. There is a slow deterioration. And this in-between stage between normality and being demented is what we are interested in today, and this is the topic. So Ron Peterson from the Mayo Clinic defined it in the following way, that there are complaints of memory problems. So if you don't complain, probably everything is okay, maybe. There also should be objective changes that can be measured, but only maybe in memory, but other cognitive parameters should still be normal. And particularly, activities of daily living should be normal, so the person cannot be defined as being demented, although they have some problem. So the memory complaints should be acquired, should be new. I mean, this is not stated in the original definition, but we understand that if somebody always has been a little bit retarded and has not changed, this is something else. The complaints should be persistent. It's not that today something happened and they complain and then tomorrow I'll say, no, I only dreamed about it, or it's not enough. The complaint should be persistent. There should be these objective changes. Activities of daily living should be normal. And it's, again, the original definition did not mention this, but I think that it's obvious that you should exclude depression. So if a person is depressed, they may complain about this or that, but once the depression is cured, then of course this will disappear. We should always think about psychosocial stress that can also lead to dysfunction, and drug and alcohol abuse, etc., should also be excluded. So the question is what is MCI? Is it a disease? Is it a disorder? Is it a clinical entity? What do we mean by this? And the relationship to Alzheimer's disease is obvious, because the implication is that if somebody has MCI today, they will have Alzheimer's disease tomorrow. But we should remember that although many people, if you do MRI on them, show in fact that they have hippocampal atrophy, which are the sign of Alzheimer that you see in Alzheimer's disease. This is only 75, and 25% do not. About 70% convert to AD within 5 or 6 years, but 30% do not. And most have Alzheimer's pathology at autopsy if they die, but many of them continue to live well, so we don't know what happened to them. So the important thing is that it's heterogeneity, that not all people develop on the same pathway. Then there are several subtypes of MCI. So MCI is heterogeneous in its presentation. It can lead to Alzheimer's disease, as mentioned before, but also to vascular dementia or mixed dementia, or it can be non-progressive and maintain the same, or it may be secondary to treatable diseases. I mentioned depression. I can mention several others. So here's the etiology. So you see the heterogeneity not only in the clinical manifestations or in the prediction, but also in the etiology. So beside depression and anxiety, people with post-traumatic stress disorder also complain. People with degenerative diseases, here on the right, can have it, of course. And again, it's not only Alzheimer and vascular dementia, but also Parkinson's disease or dementia with Lewy body or frontotemporal dementia, and particularly NPH, which is reversible. Toxic or pharmacological causes, benzodiazepine overuse, antidepressants, although they are needed to relieve depression, they by themselves can cause problems. Alcohol and barbiturates can do the same. And we can see mild cognitive impairment also in people who have immune disorders, for example, multiple sclerosis. Many people with MS have cognitive impairment, as well as in lupus or antiphospholipid syndrome. But also other etiologies, deprivation, sensory deprivation, those old people who are left on their own by themselves without any communication, with any connection with the world. Social isolation can also lead to this. Hormonal dysfunction, infections, Borrelia, syphilis, HIV, and of course trauma. All these can lead to cognitive impairment, and each one is different in its etiology, so therefore it needs to be dealt with differently. And the simplistic idea is that memory impairment leads to Alzheimer's disease. Language, if somebody has not memory, but rather language dysfunction, which have occurred in the recent past, then maybe it will lead to frontotemporal dementia, primary progressive aphasia, executive dysfunction to frontotemporal dementia, or maybe to vascular dementia. People who have practice problems, practice dysfunction, corticobasal ganglionic degeneration, and REM sleep behavior disorder accompanying the cognitive impairment might suggest that these people will develop dementia with Lewy body disease. So it's many causes come together to MCI, and we should recognize this. And when we treat or when we deal with an individual patient, we should consider that there is quite heterogeneity because they are different in their outcome. So, of course, if people have depression, they are potentially improving, or anxiety. If they have mental retardation, there's no reason to think that they will decline, so they are stable. But people with metabolic impairment, or renal dysfunction, or anemia, again, potentially improve. But we're talking about, mainly we think about brain aging, which will be progressive and lead to one or the other of the old age dementia syndromes. So is MCI really incipient dementia? I think the answer is clear that not always. And the question is who and who will deteriorate and who is not. We can talk a lot about white matter lesions, and which have cardiovascular risk factors to them, and they are associated with cognitive impairment by themselves, and particularly when they interact with Alzheimer's disease. And so MCI is not a single clinical entity. It includes many forms, many etiologies, different rates of evolution, and some people may not progress or even improve. So there are several community-based epidemiological studies where patients have been, or people, normal people or people in the community have been assessed, and whoever was diagnosed as one or the other, the investigators came back to them a couple of years later to see how well they're doing, who is progressing, and turned out that a substantial minority of them said, we're okay. We don't know what happened 2 years ago. Maybe it was something happening there, but nothing bothers us anymore. So some people improve or recover from whatever it is. So the presence of unaccounted for MCI predicts the development of dementia, particularly if associated with gait disturbances. And patients with MCI should be recognized and monitored for cognitive and functional decline due to their increased risk for subsequent dementia. So what can we do? We should look for the risk factors, if they have risk factors. So some of them can be dealt with and some not. So if they have ApoE4 genotype, then of course they are at higher risk, but this we cannot do anything about. But other risk factors can be important, so particularly cardiovascular risk factors, which we'll mention in a minute. Social isolation is an important parameter, and when we see these people, we should try and ameliorate this. I don't know about the possibilities in Greece, but in Israel we have social communities, clubs that help these people. Physical activity is important, and again, these people, these old people cannot move, this hurts, and this, that, and we should try to encourage them to be involved. Cognitive stimulation is important. If these people who come to me and tell me, look, I don't remember as well as I did before. I mean, maybe I should do something about it. So I tell them about all these things I've mentioned before, but also tell them about cognitive stimulation. And they say, oh, that's okay. I do crossword puzzle every day. And they say, that's not good. Crossword puzzles are not good enough. I say, my wife does it all the time, but I know it's automatic for her. What you should do is something constructive. So what I suggest to them is to write their own history. And I tell them, look, don't forget, your grandchildren don't have any time for you now. They have their own business. They don't know much about you, and particularly not about your own childhood and growing up. You should write it down. And once you die, they will be sorry that they didn't have time to ask you this question, but here they will have the documents. And this, I think, is, and they tell them, this, I think, is a good stimulation for you, because you have to remember, you have to recall, you have to record this. You have to think back and correct what you did, both in the phrasing and also in the content. Maybe you have to look up something. You talk to your cousin and correct some things. So this is really cognitive stimulation that I encourage very much. And of course, many of these people have depression, although they do not. They are not really suicidal. They are depressed because of the conditions, because of the environment, because of fears of what's going to happen to us in the following years. So all this has to be treated, not necessarily pharmacologically, but if there's not indication for drugs, other things can be dealt with, like those that I have mentioned, and as well as others. So I think the take-home message is the term mild cognitive impairment is of limited clinical usefulness. The diagnosis is arbitrary. Why take one standard deviation or 1.5 standard deviation? I mean, it's not a biological or physical difference, just arbitrary. And the underlying pathology is not the same. Some people have this, some people have that, some people have Alzheimer pathology, some people have vascular pathology, mainly have a combination of different pathologies. And the use of the term as a diagnosis is not productive. So if we tell a person, look, They come to me and I say, okay, that's easy. This is what we call MCI. The next thing they do when they go back home, they open the computer, they look, they Google MCI, they find out that they're going to develop Alzheimer's disease within a couple of years. So this does not help them. So making this diagnosis is not going to help them. So I don't never use this diagnosis with a patient. Maybe when we discuss with each other, I can say that this patient whom we both saw and complained, I think it's MCI, somebody else thinks differently. It's a common parlance between us, but it's not a diagnosis because it's a problem. So is MCI really incipient dementia? And again, I say no. Here are the limitations of the definition. It's based on complaints, but the complaints are subjective, depending on personality and psychological state at the moment. So the fact that we demand this is a problem. So what if I think that I'm okay and my wife says I'm not okay? So my judgment, for example, may be this problem. So if somebody's judgment is incorrect, of course, this is a problem. Maybe it's the beginning of dementia. And my wife always tells me that my judgment is incorrect. And I ask her, but is this new? And she says, no, you've always been like that. So I'm relieved, at least not getting much worse. Dependence on cognitive tests to make the diagnosis, to say whether a patient is 1 standard deviation or 1.5 or 2 standard deviation below the normal, is a problem by itself because we're not told which cognitive test we should do. And if we don't agree upon, then maybe one cognitive test will say us one thing and another will tell us different story. So again, it's not operationalized. The definition is not operationalized in this way. And so this is another problem. So on the one hand, there is a problem of maybe I'm not as well as I was 5 years ago, but maybe I complain because I'm worrying too much because this is my personality. And then the overlap with early dementia is also a problem because again here between the change from normal cognition to early dementia does not occur overnight, and sometimes it's not going one way but fluctuating. Today I'm worse and tomorrow I'll be better again because of whatever reasons, and the results of the test again are not the same on subsequent tests. So this is again a problem. So I think so what do I do? So I mentioned the vascular risk factors. So of course, antihypertensive therapy is important. Lipid-lowering drugs. Many people do not know what are their cholesterol levels. So let me ask you, how many of you have measured your own blood pressure in the last 6 months? Okay, so less than half. How many of you know what your cholesterol levels are? The same people. So these are the people who look after themselves. So this is a problem because we know that cognitive decline occurs in people with these vascular risk factors, but it's midlife risk factor which is important. It's not late life. If a person is demented and you tell them, look better after your blood pressure, it's like telling a person who has got lung cancer to stop smoking. The horse is out of the barn. Antioxidants, maybe, folic acid and vitamin B12, I think are important, and there's no danger in taking an overdose of them, and maybe anti-inflammatory drugs. So cocktail, I take folic acid and vitamin B12 daily. I've never measured them. I don't know if I'm deficient. I'm sure I'm not deficient because I take them all the time, so I cannot be deficient. But if there is an excess, it's not dangerous and will flow out in the urine. Statins, I think the same thing. So we don't know what is the level. When I was a medical student, I remember very clearly, we went on a round and the professor of medicine stopped at one bed and said, this woman needs to be treated because her cholesterol level is too high. It was 290 at the time, and the level threshold level then was 250. After I graduated, it was lowered to 240, then to 220, now to 200. People who have coronary artery disease, the cardiologist next door will tell them should be even lower than that. Again, it's not an absolute number, and of course, the statins do not only reduce the cholesterol levels, they do other things. Many of them have anti-inflammatory drugs, anti-inflammatory effects, and this is may also be important, maybe as important as the cholesterol, maybe even more. So taking statin is not important. Non-steroidal anti-inflammatory drugs, maybe ACE inhibitors. I have a friend who's a professor of medicine in the United States who say that ACE inhibitors should be added to the drinking water. So if everybody will have their blood pressure reduced by 5 millimeters of mercury, it will be good. No harm will be done. So, of course, lifestyle changes are important. Smoking cessation. In Greece, we still see quite a lot of people who smoke. Again, midlife factor, which is important. Old people throw out smoking anyway, but if they haven't, this is our task to tell them to do. Healthy diet is important, and we are on the Mediterranean basin, so we should use what we know about the benefit of the Mediterranean diet. Overweight reduction is important, physical activity, cognitive activity I mentioned, and alcohol abuse is dangerous, but a mild alcohol use is beneficial. So many of these people who have insomnia, and I tell them, you know, instead of a drug or in addition to a drug, have a glass of red wine before you retire, and it will help you. And with this I will end. I will invite you to Coney, to the meeting that we have here in Athens in a few weeks, and this will be an excellent meeting. Again, I will show what I showed in my previous slide, but maybe you've not all been here. We have an excellent dementia program, but of course we also have a stroke program and the MS program and the Parkinson program and this and that, every part of neurology. And we have section heads for each of them, and with the Greek section head as well. So the dementia program, particularly because we are here in this meeting, I mentioned this. So Professor Thessaloniki was good enough to undertake the creation of the debates there with Lefkos Middleton, who's a Cypriot but now living in London for many years, helping us. So they do it together. So there are many debates. So are animal models for Alzheimer's disease useful, or have they? And again, so we have 1 hour dedicated to this topic. And Magda Solaki will be the host, so she will explain what is the background, so how much is being done, what is being done. And then Marwan Sabag from United States now, but he's, I think, Iranian in origin. So he says that animal models have led us, have not helped us a lot. I mean, we wasted a lot of time on them, but they did not prove anything. And Spiros Georgopoulos will say, no, they are important. They will carry the truth forward. Or that diet, is it still an unresolved issue requiring further nutrient mechanism-based research? And Nicholas Skarmias will be the host, and Roger Bullock from United Kingdom will say yes, and Evangelos Evangelo will say no. Does cognitive reserve prevent dementia? GWAS, genome-wide association studies in Alzheimer's disease are a waste of time or money, and can sleep measurements tell us about the neuropathology underlying dementia? Each of them have 1 hour, so each person has 15 minutes to defend, and the other one to oppose. Then there is time for questions and comments. They have time for rebuttal, and then we go on to the next topic: is mild cognitive impairment the I talk about now, is it a useful concept? And Professor Giannakopoulos will be the host, and Magda will say, yes, it is important, and Maurice Friedman from Canada will say, no, it's a useless term, much along the line that the criticism that I have dealt here, I think. And then, so this is one day of debates, but on another day we have also special lectures, which are also of great interest. Are low-risk genes for Alzheimer's disease really important? So we know that ApoE4 is absolutely important, but we have identified maybe a dozen other genes with a small effect. So the question is, are they important or not? Cornelia van Duyn will tell us this. About the tau issue, tau is important also, not only in Alzheimer's disease, but also in frontotemporal dementia, in other disorders as well. And so what is a tau connection? Leah Greenberg from United States and Brazil will tell us this. Can genetics teach us about human memory? Andreas Basotiropoulos will come to Athens for that occasion and will tell us this. I will tell again why have we failed to cure Alzheimer's disease. I did a couple hours ago. And Magda will tell us about non-pharmacological intervention in dementia. And she is a leader in this and contributed a lot to this. And innovative technology for cognitively impaired people by Luisa Spiro. So you're all invited to this. We have also a dementia roundtable where Greek people will tell us about what happens in Greece, and you should be interested in that as well. So I thank you very much for your attention.
Thank you, Professor, for the excellent presentation. Are there any questions, please?